Okay. Oops. Okay, so I'm going to talk a bit, or mostly about sustainability research, and then just a little bit extra at the end. And I think part of what generated this discussion was that we just recently submitted, but didn't get accepted, an abstract on at APSA looking at our travel to APSA. And so I thought, since we've talked about the abstract a little bit, like it would actually be helpful to kind of go through some of the methodology in terms of how the study was done. And so what we wanted to do was to look at the environmental impact of travel to APSA. And my purpose for that is that I think on some level, we need to quantify what our emissions are so that we can use that to generate awareness about the impact of the meeting and try to then explore mitigation strategies. It wasn't an attempt to advocate for a virtual only meeting, which is relevant when you get into why we chose to just look at the emissions, right? So since we're just looking to try and say, hey, this meeting generates a lot of emissions, we don't need to do a head-to-head comparison with going to the meeting versus not going to the meeting. And when you're trying to look at the emissions, there's a lot that goes into it, right? So by looking at only the travel to and from the meeting, we're actually able to narrow the scope of the study to a manageable amount of data, right? So all we did was we looked at starting in your home city and then going to Orlando, which is where the 2023 meeting was. What we didn't take into account is how much traveling did you do at the meeting? You know, how would you allocate the emissions from the hotel HVAC system for the meeting rooms that we're in? What about the meals? You know, non-plant-based meals, reusable, non-reusable, single-use stuff that comes in our box lunches. Like all of that stuff would need to be accounted for if you were doing a full study of all of the emissions. You know, the hotel linens, what's in the room as far as amenities, you know, what's the energy to keep the pools running, and, you know, and did you bring a partner with you, and was their travel accounted for also? So just looking at travel to and from, it gave us a way to consistently say, like, we know this is definitely happening. And even though it's only a fraction of the emissions, you know, if we can show that it's still significant, then it gives credence to saying, hey, we need to mitigate what we're doing. So as I said, we looked at the distance from the home city to Orlando, arbitrarily decided if it was less than 200 miles, that person probably drove. If it was more than 200 miles, then I used two different calculators for the distance between the closest airport to Orlando's airport. And I used the two different calculators just to validate that the numbers were accurate, and there was really very little difference between the two different websites. And then we broke down the distance in travel, short haul, medium haul, and long haul. And you'll see in a second where those numbers come from. But once we had the number of people that were traveling from different cities, we could calculate the total miles traveled, and then, you know, by which route, whether it was by automobile or by airplane. So then the question is, all right, well, that's great, you know, the distance. How do you translate that into emissions? And there are things called emissions factors. And basically an emissions factor is a representation of an attempt to quantify, you know, the emissions that are emitted for a specific activity, an industrial activity, you know, travel, whatever the case may be. And these emissions factors, like the EPA has some that are published. There's also large databases of emissions factors that are out there, right? So, you know, you want to know, like, if you start with a raw material of cardboard, you know, how much carbon is generated in making, you know, cardboard, you know, by weight, by volume, you know, whatever the case may be. So these are out there, and they're industry standards. Obviously, over time they get updated, but it's there as a resource to try and translate. All right, well, we know everybody's traveling to the meeting, but how much carbon is that? So this is a screenshot from the EPA website, and one of the categories of emissions is business and employee commuting. And so for passenger car, and then for air travel, and this is where I came up with a short, medium, and long haul breakdowns for the air travel, we know what the emissions factors are. And this is actually not only CO2, but also methane and nitrous oxide. So now that we had the distances and we take these emissions factors, we basically, it's just simple math. And we know we had 757 people attended, 50 drove, 707 flew. We have the breakdown of the distances from the air travel in terms of the number of people that were short, medium, and long haul. And when you do the math, we come up with 267,000 kilograms of CO2, 1,200 of methane, and almost 8,500 of nitrous. Which, like, what does that mean, right? Like, that feels like a lot, but like, practically speaking, right, what does that mean? So then we can go back to the EPA website, and they have a greenhouse gas equivalency calculator. So you can take either a certain amount of energy used or emissions generated, which is what we had in this case, and plug it in on their website, all the different numbers, and it'll spit out like this is the equivalent of cars driven, or the number of houses heated per year, or something that's trees that would need to be planted to offset, right? So it puts it into something that people can actually conceptualize and wrap their brains around. So plugging our numbers in, our APSA travel to and from last year's meeting was the equivalent of 568 gasoline-powered passenger vehicles on the road in the United States for a year. So it's roughly 12,000 miles of a standard, mid-sized car on the road. So it's not an insignificant amount of emissions, and it's only a small fraction of what we generated for the whole meeting, right? And so my hope was that we would have been able to take this and present it at the meeting, but I think, we have to think about, and we can obviously discuss this later, how as a group do we get this information forward to the APSA leadership? Because I think it does give credence to say, hey, we need to mitigate what we're doing, right? We're not going to not meet in person. I don't think anybody wants to go back to that. And there's definitely advantages to meeting in person. So if we're going to do it, like, how can we do it better? So that's where the study came from. That's how we did it. It was limited just to travel, again, because the scope of the study, like, that was a manageable scope. And that scope is an important concept. And the next thing that I'm going to talk about here, we'll talk about the scope again. So I don't know if anybody has any questions just about this study that we did, or if you want to wait until the end. But this was the abstract that we submitted, and we'll generate a manuscript and see where else we can take it.
I'll just say, Colleen, thank you so much for presenting that and talking to us about that. That was so amazing. Colleen did all of that and like had an abstract out in like a week and a half. It was amazing. And I was so curious how you did it, and what your methods were. And so that's why I asked Colleen to do this expert talk for us, so that I could learn a little bit about how to calculate the emissions or put some sort of metrics on it. But anyways, we can talk about that a little bit more later on. Colleen, go ahead. I just wanted to say that.
All right, perfect. So the next study that I want to talk about is related to appendicitis. And the work that I'm going to present was actually my final capstone project for my master's. And what I wanted to do was compare basically 3-port appendectomy to single-port appendectomy, because my premise, or my basis for this, is that if you can do an operation more than one way and have equivalent clinical outcomes, all things otherwise being equal, at some point, the environmental impact should start to be a consideration in the decision making that we take in the operating room when it comes to preferences and equipment that's used. So clinical non-inferiority, cost efficiency, and environmental impact of pediatric appendicitis. So what I wanted to do was show clinical non-inferiority between a single-port laparoscopic assisted appendectomy and a kind of a standard 3-port appendectomy, and then also look at the environmental impact and the cost. I know there's different ways of doing single-port. At Cohen's, this is the approach that we use with the 10-millimeter scope with the side working channel. We mobilize the appendix, we bring it out through the umbilicus, and then essentially do like an open appendectomy through the umbilicus. So when I'm talking about single port or the transumbilical laparoscopic assisted, this is the approach that we're using. So first, the clinical piece. So if you figure that on average, the surgical site infection rate that's reported is 2.5%, if we did a power analysis for demonstrating non-inferiority of not increasing the surgical site infection by more than 2.5%, we would need sample sizes of roughly 480 patients. So that was just, figuring out what our study size needed to be. So I did a 3-year retrospective review of our cases, ultimately ended up analyzing almost 1,600 cases. We did 932 single, and we did 182 single converted to multiple. And clinically, and I'll talk about this a little bit more later, but it is relevant to combine the single and the singles converted. And then the ones that started out multiple and then obviously stayed multiple were 497. We didn't have any converted to open, and our follow-up rate was roughly 88%. So from a clinical standpoint, nothing that in terms of like statistical significance, some of these things are statistically significant, but not clinically significant. But the two areas that are important is the BMI and the intraoperative findings, right? So our BMI was higher in the cases that started multiple port and stayed multiple port, right? So there is some clinical decision-making going into the choice. And then also more likely to be complicated appendicitis in the multiple. So that, again, like something about the imaging prompted somebody to say, hey, you know what, we're just going to do this with 3 ports. In terms of the outcomes from the clinical outcome standpoint, really no differences other than length of stay, and that's not really clinically meaningful, but particularly there was no difference in the surgical site infection. If you compare the ones that started out 3 port and stayed 3 port, and then the ones that started out single port and either were able to be completed that way or included the conversion group. If you look at surgical site infection, no significant differences across the spectrum, whether it was simple appendicitis or complicated appendicitis, irrespective of the operative approach. So all of this to say, clinically, no inferior, like the single incision approach isn't inferior to doing a standard 3-port appendectomy. So then we want to get into cost and environmental impact. So again, it goes back to defining, well, what's the scope of the study, right? Because there's a lot that goes into doing an appendectomy. And so I chose to limit it to all items that basically touch the back table in the operating room. So that includes, the stuff that's here in the picture, disposables, gowns, sutures, staplers, ligature if somebody's using it, trocars, all of the kind of the equipment stuff that's used during a case. When you're doing this kind of study also, you'll have a category for capital goods. So for example, the reusable instrumentation, that doesn't go into, or it depends on how you decide to define things, but you can define the capital goods and those don't go into your environmental impact because, you buy a laparoscopic instrument tray, that's getting used for a lot more than just appendectomies. And it's a piece of equipment that's going to be used over and over and over again. So the impact that the one case that you're doing with that particular set of instrumentation is going to be negligible, and it's not really going to change the outcome. And then what we excluded is like all the other stuff in the operating room, the HVAC, the anesthesia, bear hugger. And part of the reason why we could exclude all of those things is that when we're doing the comparison between the 2 different operative approaches, all of those things are the same, right? So they're not going to change the conclusion of the comparison. So, all of this stuff in the picture, yeah, that's part of the environmental impact of what we do every day, but I didn't include it in the study because it's not going to give me that, it's not going to contribute to the direct comparison between the 2 different approaches. And so the other piece that was a little bit of a variable is that, we're roughly 12 surgeons in our group and we all do things a little bit differently. So how do I compare one case versus another? And so what I did was I went through all of the cases and tallied the equipment that was used for each case, and then just averaged it out across all of the surgeons in the group to kind of define what our aggregate equipment use is. Somewhat limited because it's retrospective, it's based on people's operative dictation. So, there might have been a suture that was open that wasn't dictated used, and so we wouldn't necessarily be capturing that. But based on the aggregate case, all the things on this page were consistent for everybody across the group because they're some of just the standard trays and pans, but you get into things like endo loops and staplers and, suction irrigator. they're not used by everybody. They're not used in every case. And so these fractional numbers are basically on average, we're using, 0.25 ligatures, in one instance, or we're using, 0.13 laparoscopic retrieval bags, right? So it gives us a way to do the math, to do the comparison. So for the cost piece of it, this was just something I learned as I was doing this and trying to get it through our IRB. We're not technically looking at cost effectiveness. We're looking at cost efficiency, right? So how can we do the operation in the most efficient way possible from a cost standpoint? And so if we take our aggregate case numbers and we multiply it out by costs, across the board, the cheapest case was the single incision approach. The converted case was the most expensive approach, but because there were so many singles that stayed singles, the singles plus converted are still cheaper than starting out with a standard three-port approach. And these numbers are basically the same, whether it's for simple or complicated appendicitis, like the proportions and the relevancies don't change. So then the next question is environmental impact. So and kind of the technique for this study is life cycle analysis, which is, it's a cradle to grave environmental impact analysis. So you want to start with the raw materials and then end up at your landfill or your disposal, but it includes, or ideally includes, the manufacture, the shipping, the energy that goes into the use phase. So it's really very comprehensive. As I said, my scope for the study was limited to the back table. And then the other thing you need to define for your study is the functional unit, right? So that when you're comparing one approach to another approach, the functional unit is also comparable, so that you're basically doing an apples to apples comparison. And so when you do this type of study, you also need to develop a process map so that you make sure you're getting all of your steps. So we have our raw materials. There is the instrument packaging, processing at the factory that gets transported to the hospital. It gets used. It then gets either landfilled, or the reusable instrumentation is going to go through, reprocessing and come back to the operating room. So product composition, if you've ever looked at, and I've got graphics, so I think the slide is going to be slow coming up. Like, you look at this stuff and it's like, what's it made out of? And if you read the package inserts, that information isn't there. So it's really kind of hard to know, is like, what kind of plastic is this? What percentage is metal? What is the metal? And so it can make doing the raw materials calculation a little bit challenging. This article, which is now a few years old, was a study that compared environmental impact of a hospital in Canada, a hospital in the US, and a hospital in the UK in terms of the operating room itself. And what they did in this study was they weighed all of the waste at the end of the operations, and they said, you know what, most of this is plastic. And so when we go to our emissions factors table, we're just going to use a composite emission factor for plastic, because the majority of everything that we're using is plastic. So there's precedent for trying to bring this down to a more basic calculation. So what I did was I basically looked at the products. If it was mostly plastic, I assigned, a standard plastic emissions factor. If it looked like it was, mostly a metal, I came up with a metal emissions factor that I used. And so for each of the items that was used in the operating room, I basically took it and weighed it in its sterile packaging. So I knew what the weight of the product was, so that when I went back to the emissions factor, it was, an emissions factor per kilogram, and I could calculate then per item what the emissions were. The raw materials, so as I said, I weighed the items in the sterile packaging. The other component of packaging is the tertiary packaging. And this has actually been a challenge for me to get good concrete numbers. And this is one of the challenges of being in a big healthcare system, is that we have a centralized depot for all of the supplies. And what comes to our individual hospital, maybe only 4 boxes of suture that were in a box of 20, and it's in a plastic bin that gets transported back and forth. So I don't actually have the cardboard box to weigh. And, so that's been a little bit tricky in getting the secondary and the tertiary packaging. Then when you start to look at manufacture, there's a lot of components to this that are tricky. Where was it manufactured? What's the energy mix for where it's being manufactured? And so what I could come up with was, at least there's an emissions factor out there that's been published looking at sterilization. And so you could say that for each disposable item, you could use an emissions factor for single item sterilization. The transportation piece is also tricky. Where are things made, right? So you look at the packaging for Ethicon, and some of it's made in Mexico, some of it's made in Puerto Rico, but Ethicon's got headquarters and depots that are all in the United States. And so where is it coming from, and how is it being shipped? If it's coming from Puerto Rico, is it freight and then truck? If it's coming from Mexico, does it get on a train and then get transported to a truck? So there's some you do the study and then you go back and you do a sensitivity analysis and decide, all right, well, if this was all truck or all rail, how much does it change it? And does that significantly or meaningfully impact the difference? Your use in the operating room needs to be calculated. For all of this stuff, since it's just disposable, like there's really minimal environmental impact unless you calculate like the ATP consumption of the surgeons doing the case. So this was actually an easy one where we could say we don't actually have any data for this phase of the life cycle. And then after the operating room, everything either goes to a landfill or is going to be sterilized and then reprocessed. So you have to have transportation to the landfill. You need to know the distance. You assume it's probably going on a truck. Significantly contaminated things coming out of the operating room might be treated as regulated medical waste, which has a higher emissions factor because it needs to be additionally processed. For straightforward appendectomy, really none of it should be regulated medical waste. And so I just did straight landfill emissions factors. And so all of that to say, like at the end of the day, the highest environmental impact was from our converted cases. The lowest was from the singles. When you combine those two, though, it's still lower than if you start off with a 3-port appendectomy. And so if nationally we're doing roughly, 80,000 appendectomies, if all of them are done open, or excuse me, all of them are done with 3-port, it's 2.3 million kilograms of CO2. Whereas if you start with a single port, even if you have to convert, in aggregate, it's only going to be about 2.1 kilos of CO2. So you're saving 250,000, which is roughly 50 cars on the road, which is not a huge number. But this is also only one operation in like the whole spectrum of healthcare, and so it's a potential way to think about this differently. And again, it's I think when you have two different choices, all things otherwise being equal, we really need to start thinking about the environmental component of it. And life cycle analysis is a tool that's used a lot in healthcare studies looking at the environment. It can be fairly tedious to do, and there are components of it that can be challenging just in terms of defining the scope and then actually getting the data that you need to do the actual calculations. But the final conclusion from that, this is clinically non-inferior, it's more cost effective, and there's less environmental impact. This actually was accepted as a quick shot for APSA, so you can now not go to that and go listen to something else because you've heard it here already. And then the next thing that I wanted to touch on is you actually don't always have to do the research. Like there's a lot of good research out there that you can take and apply to your own organization. And so this, the work with isolation gowns is actually something else that started out as a project at school. But this picture is from our hospital, and I suspect it's not unique to our hospital, right? Like anybody who's walking down a hallway, like there's, especially like at this time of year when every child seems to have some sort of respiratory illness, there's disposable isolation gowns like filling up trash bins all over the place. So this is a study that was done previously and published. That's a life cycle analysis comparing reusable and disposable gowns. And just to go back to the point about the functional unit. So this is where the functional unit becomes relevant. So when you're comparing a disposable gown and a reusable gown, if you do a 1-to-1 comparison, you're not actually comparing apples and oranges, because the disposable gown goes in the trash and the reusable gown is going to get reused, right? And so rather than saying we're going to compare one gown to one gown, what they did in the study was they compared 1,000 uses. So for the disposable gowns, that's going to end up being 1,000 gowns, but for the reusable gowns, it's going to be a much smaller number than 1,000, because to get 1,000 gown wearing events, you're going to be using some of those gowns multiple times. So what they found in this study is the reusable gowns across the board did better in water consumption, energy consumption, solid waste generation, and greenhouse gas consumption. So what we did was we basically took the data from their study and scaled it to, these are not exactly the Northwell numbers, but they kind of said, hey, you can use these for your study, but these aren't the exact numbers because we don't want our exact numbers like out there in the world, right? So we basically said, okay, across our whole healthcare system, if we assume we're using 8 million gowns, in a year, what does that look like if we want to do it in disposable or into reusables? And so reusable gowns, the published data is that you can get somewhere between 75 and 100 uses per gown. So I basically scaled it and I said, all right, we're just going to say we're going to get roughly 85 uses per reusable gown. So instead of buying 8 million gowns, we can get away with getting, closer to, 93, 94,000. And then based on that, these numbers and the data from the study that was published, what are we going to save, right? So we would be saving nearly 1 million kilos of CO2 and global warming potential. We'd be saving 329 kilos of blue water and saving, 482,000 kilos of generated landfill waste. So again, just we'd be getting fewer gowns, we'd be generating less waste. And then when you get into the cost component, okay, the reusable gowns are more expensive, but we're buying less of them. So that's a cost savings. And then you say, well, but you have to launder the reusable gowns. Okay, that's true. But once you add the laundering costs with the purchase cost, it's still actually considerably cheaper than buying new gowns for each disposable use, right? So at the end of the day, while I care about the kilograms of CO2, the hospital cares about this cost savings box at the bottom, right? So that's another, I think, key component when you talk about sustainability research is how can you tie this to the bottom line dollar so that you can get the attention of the people listening in the front office. Now, having said all of that, this has been in the works for about a year. So the top left corner is a picture of the hallway of our hospital. And you can see on each door, there's this, unit that is hanging there, which is then there's a picture of it in the bottom right corner, gloves across the top, gowns and masks at the bottom. The reusable gowns are big and bulky. And so while we can fit 20 disposable gowns on the door, we'd only be able to fit 2 reusable gowns. So from a clinical functional point of care distribution, it's not practical to say, well, we're just going to have 2 gowns on the door at a time because a team comes into round and you need almost, 3 or 4 times that many sometimes, right? So how do you do this differently? And there's any number of different possibilities that are out there. What we're looking at is this, cloth stuff sack that would get hung on the door, right? So that's a possibility. Part of the consideration is there was a lot of money spent on all of these other gown dispensing units that are currently hanging on the door. Now we're talking about having to go back and reinvest, right? So this is where the study is great, but the practical application can be really challenging. And I think one of my personal frustrations is our healthcare system is a signatory of the, Health and Human Services Climate Pledge, and they are active on the, the Practice Green Health Climate Council, but our hospital leadership or our system leadership hasn't actually made an organization facing announcement about this. So I've got a fire lit, hey, we need to do this a year ago. And all of the people that I need to bring along are oh yeah, this is a great idea. Not this is a mandate from the CEO, we need to do this because we have this defined goal. So, just again, I think this is a common frustration for people that are working in this space. But all this to say, the research can be tricky. You don't necessarily have to do it yourself because a lot of it's out there and you can just take it and then do the math to make it applicable to your own situation. And then the last thing I just wanted to touch on, I've actually been working with our medical school to start integrating sustainability into our med school curriculum. I don't know if you guys are aware of this, but this is, the students are hungry for this. And there's actually a planetary health report card that's a student-led initiative that grades medical schools on how they're doing in their sustainability teaching and education. Emory actually is the highest scoring, and they're the only ones that are like an A, and everybody else is like a distant B and C minus. Our organization doesn't even make the list, so this is like new for us. And for anybody that might be interested in doing this, there are a bunch of there are existing collaboratives out there, so you don't have to start from scratch. A lot of the materials are available online. These are just screenshots of some of the different websites. This Columbia website and this global consortium, I think, is a little bit more robust in what they have to offer, because they've got, modules and slides and things that are out there that are pre-made for, a number of different subspecialties. And so, again, just I put that out there as it's doable, and it's not like you have to start from scratch. So, having said that, the only other thing I realized that I forgot to put in the slide presentation is that we also just recently launched a sustainability community through the American College of Surgeons. So if you're an ACS member, we would love to increase our membership on that and get some more discussion going. And so please consider signing up and joining that so that those conversations can be a bit more robust. So having said that, I'm happy to answer any questions.
Hey, Colleen, this is great work. This is a lot of work, obviously. A couple of questions. And this sounds kind of sideways, but did you factor in things like an open appendectomy? And did you also, not like anyone does it anymore, but I mean, how cost effective is that? And how about non-operative therapy, where you don't use any operative stuff? Again, I realize not everyone does that either, but that it is kind of the other options that we sometimes get on the menu of how we treat these kids.
I actually didn't think about the non-operative arm of it, so it's an interesting question. As far as the open approach, my thought was, I don't think I'm going to convince anybody to go back to that, right? And so I think the likelihood of having any success there is pretty minimal. Having said that, I don't know that it would be that much less of a factor compared to the single incision approach once you sort of eliminate the capital goods purchase, right? Because your reusable instrumentation is there. And so when we do it through that single incision approach, essentially we're using the instrumentation to get the appendix out, and then we're just the disposables that we're using are what we would use for an open. So I don't think it would probably be that much more than it, but I specifically didn't look at it because I figured we're not going to make the case to go to open appendectomy. What I would love is that this makes the case for nobody should ever think about doing a robotic appendectomy, right? Like, I mean, but to be honest, like when I was at the ACS meeting this fall, there were a couple of like abstracts presented of robotic cases, and it's like, why? Like, there's no benefit to it. And the environmental impact, there's a really nice life cycle analysis of hysterectomy, and it's a couple years old now also, but they look at robotic, laparoscopic, open, transvaginal, and the robotic clearly has like the worst impact, right? And so, I think, again, the idea is we're not going to get people to take steps backwards, but to just be thoughtful in what they're doing. And if there are equivalent outcomes, maybe then this is the next variable to think about.
The other question I had is follow-up, and I don't want to take up all the time, but did you factor in, and I may have missed it if you said this, the duration of a case, which also means lights on and gases and stuff that are used in the operating room, and drugs which are used in the operating room? I mean, it gets really fine at that point. And maybe it's probably, I don't know how big that impact that is.
So I didn't look at that for a couple of reasons. One, case duration, finding that in our EMR, it's actually not accessible because we're still on Sunrise, like it would mean going into our other system. And so for the sake of just getting through the cases, I didn't look at that. But I also didn't, like, that to me would be outside the scope of what I was trying to do with just the comparison of the back table stuff. But, and again, this goes back to how you define your scope, right? Because you could look at, from the perspective of is the transumbilical approach slower? And even though you're having an environmental impact savings in your single-use disposables, it's being completely offset by the fact that your HVAC is running for an extra hour, right? Like, I'm just making up that number. And case in point, I think our single cases are probably at least on par with our multiples, and maybe are even a little bit faster. But again, that's where defining the scope for this study, or any kind of a life cycle study, it feels like a trivial point, but it really is very important to have like clear, boundaries for what you're looking at.
Great work.
Thanks.
That is
Colleen,
awesome. Oh, go ahead.
I'm so impressed because I've done some life cycle analysis as well, and yeah, I know how much work it is to go through all those raw materials and all those things. You did a really amazing job trying to compartmentalize it as best you can to get as good of an estimate as you can. It's really, really cool. I'm really excited to hear about it.
Thanks.
Yeah, that's phenomenal work. Thank you so much for talking to us about that. I really think that putting this video up hopefully will help a lot of people who want to do research in this area, just to see what you've done and the steps that you took to go through that. Also, Mehul Raval is someone I'm trying to get onto the committee to talk to us. He's trying to find metrics that will work like across hospitals to try to measure emissions and make comparisons. We've had some talks, and just what you're doing, I'm wondering if there's something we'll link to that.
Yeah, I mean, when you start talking about comparing hospital to hospital, I think it gets a little bit challenging. And just even thinking through like this hospitals that are doing the HHS pledge, for those systems to quantify their emissions, it's a huge task, right? And so to come up with a way to be able to and there's also different ways of, like, you can do a cost-based life cycle analysis, which is not as precise, but for like the scale of a hospital system is probably at this point the only feasible way to do it. And so to do a direct comparison, I think would be challenging. It's a great idea though, and definitely something that's worth thinking about. So I'd love to be part of the discussion.
That's great. Hopefully we can link you guys up.
Linda, I have a question, if you don't mind. Sorry. I'm Steve Sobel. I'm at CHOP. I'm an ENT. Sorry I was late to this. I was
That's right.
asked to give some words at a fundraiser last minute and missed the first few minutes. Colleen, I have a question for you. So if I wanted to do this at CHOP, right? If I wanted to look at ENT surgeries, or do what you've been doing, how do I get started? Like, who do I need on board? What's the team I need to put together at my institution to look at this? Do I need somebody from supply chain? I mean, I figure I need an anesthesiologist. I figure I need probably somebody from supply chain. Are you doing all these calculations and measurements, or is there somebody who's got expertise either at your institution, or that if I wanted to get that, because I'm not going to be able to learn all this and execute all those calculations like you have, but I want to have somebody who can help me with it?
So ideally, you've got somebody at your organization that's familiar with life cycle techniques. If not, you can collaborate with people at other institutions. But at your own site, it's helpful to have somebody from the supply chain who can help you figure out like where stuff is potentially being shipped from, if they know, who can help you with the packaging. Some of the studies have been done, other studies that have been published, where at the end of the case, they collect the trash. And so, if you're going to do that, then obviously you need to have your environmental services people involved in it. If you can get a group of medical students that are, interested in this to work on something like that with you, to help with, being in the physical space to collect stuff or to do observations, that's helpful. but it's yeah, I would say the people that were the most helpful to me for this were the people that do the supply chain work for our operating room.
And Colleen, can I also kick that question over to Wynn? Because Steve, that's a great question. Wynn last year created this toolkit that talks about the types of people that you would want to gather, not necessarily for like a life cycle analysis like Colleen did, but for a sort of, you know, more of like a sustainability project. So when you want to tell a little bit about that?
Yeah, absolutely. And I can put the link into the chat as well. But I think that having been through this experience at 2 different hospitals, I did my research fellowship at Lurie Children's Hospital, and then I'm a current general surgery resident at Rush. And they have very different kind of strengths in the individuals that are interested and engaged in this type of environmental work, but then also in where the institution kind of already has some foothold within sustainability. So I think an initial good first step is really taking stock of who's around, kind of what Dr. Fitzpatrick mentioned, who's available and interested, and using that to help identify some projects that would be kind of low-hanging fruits to get started with. I'm also happy to talk a little bit more offline too, and kind of talk about specific areas that might be helpful to focus in. But I'll put that link into the chat as well.
And then I see Alfred put in a note in the chat to collaborate with biomedical and engineering and business departments in the university can help you potentially.
And the other piece of that with collaborating with engineering, if they've got life cycle expertise, is the access to the databases with the emissions factors. If you're not using like one of the publicly available ones, those databases are actually pretty expensive. So if the university or the institution already owns access, it's most likely through one of those other departments. And so that would be a huge asset to have.
Can I just add one thing for you, Stephen? If you want to collaborate with folks in sustainability at CHOP, I've got lots of contacts there. They are running crazy with sustainability in the anesthesia department. They're doing some really amazing stuff, and there's a lot of momentum there. And I think that, you know, a collaborative project like this that looked at anesthesia variables and surgical variables together would be really powerful, and nothing that anybody's really, I don't think, attempted to quantify. But I think that you could probably show that if you took the worst case scenario for environmental impact of anesthesia and compared it to the best case scenario of environmental impact for anesthesia, it would be at least as much, but probably more impactful than any changes that you're making as far as, like, you know, an API with 3 ports or 1. Because if they're running desflurane at high flows, it's going to blow the emissions out of the water. Whereas if they're running TIVA and you're doing a single port, your impact is going to be a lot less when you work together, which is, you know, how the real world works too. So that would be really, really cool. So I hope that you can do it. I would love that there was a cool collaboration that could come together there.
That's great.
I'm going to take you up on that.
Fantastic. That's hopefully what we want to foster in this meeting. Okay, so I'm going to